Now I am recording.
I know we have to say that we're recording. There we go. So thank you for joining us today for this conversation. As Dr. Johnson said, Dr. Campbell reached out and asked me to talk about assessing blood loss and management of blood loss. So we will kind of go over some definitions, and for the interaction piece, we would like for everyone, when we get to that point, I'll remind you again, but have your chat box pulled up, because that's how we'll be kind of interacting with each other. That makes it a little bit easier as more people get on the call. So you can do the next slide, please. So is OB hemorrhage still an issue? And the answer is absolutely yes. We are hearing more and more about our causes of our maternal deaths rising in the postpartum period with cardiovascular and coronary conditions, but we still see that for South Carolina, and this is from the 2020 legislative brief from the South Carolina Maternal Mortality and Mortality Review Committee, that hemorrhage and infections are still the leading causes for maternal mortality. So because of that, we still need to be paying attention to what's going on with our OB hemorrhages. Next slide. So I just wanted to make sure we were all on the same page as we got started today with defining what do we call an obstetric hemorrhage. So ACOG in October of 2017 gave us a new definition, or an updated definition, that defines postpartum hemorrhage as a cumulative blood loss greater than or equal to 1,000 mLs, or blood loss accompanied by signs or symptoms of hypovolemia within 24 hours after the birth, regardless of the route of delivery. So that has changed the way that we think about hemorrhage a little bit. I think it highlights the opportunity for remembering that 24-hour cumulative bleeding that we talk about. So when we make the transition of that mom from the L&D units out into the postpartum units, it's important to remember how much blood was actually lost in that early postpartum period or at delivery, and then when mom goes over to postpartum, because that additional component is there, as well as knowing that even if I don't get to that 1,000 ml blood loss, that if I have a mom who's symptomatic, then we're going to treat as if it is, we're going to treat her as if it was 1,000 or more cc's. Okay, next slide. So when we talk about management goals, and we always go back to where our gold standards are, so I brought us back to the postpartum hemorrhage practice bulletin that was released in 2017 from ACOG, and it is making sure that we are thinking about the management of postpartum hemorrhage, that we are multidisciplinary, and it's a multifaceted approach, that we are working to recognize, number one, that a woman is becoming unstable or has the potential for instability, and that does depend on what she's like pre-delivery. So all of her comorbidities, what her hemoglobin is going into labor and delivery, while we're simultaneously and kind of taking a multi-team approach to managing the blood loss, we also are working on trying to figure out what is the cause of that blood loss. So we want to make sure that we remember that everyone is staying on the same page. Well, number one, we're recognizing risk factors. Number two, that it's a multi-team approach, so everyone is kind of on board working towards this goal. And the last factor that has really been important in the last several years is making sure that we are much quicker at treating these mamas. So we want to think about treating our postpartum hemorrhage moms or our antepartum hemorrhage moms much more like the way that the emergency department thinks about a trauma patient. So we're going to be much quicker at giving blood products. So what does that mean for tasking what we do with our pregnant and postpartum women? So next slide. So again, I'm not giving you anything brand new, but I think it's always good to come back and highlight different components of things that we just kind of get really used to. So remember that we talk about different classifications of hemorrhage. So when a woman has lost about 1,000 cc's. That's about 10 to 15% of her blood volume. That's going to give her that dizziness, palpitations, minimal blood pressure changes. When she loses an additional 500 mLs, that's going to put us in that class 2. That's going to start giving much more physical signs and symptoms. So the tachycardia, tachypnea, she's going to be sweaty, she's going to be weak. Those blood pressure changes are going to be very apparent there. When we're at 2 liters, that's significant blood pressure changes. She's hypotensive. We start getting the pallor, the cool extremities, restlessness, and then at greater than 2,500 mLs, that's where we're really, like I like to say when I'm teaching, we're kind of really behind the 8 ball there because we have lost a lot of blood volume at that point. Next slide. So I adapted a little algorithm that was in the Gabe's obstetrics. And I just like the way that this kind of lays everything out. That number one, we want to start by quantifying our blood loss. And we're going to dive in deep to talk about quantification of blood loss. So the initial response to that blood loss, regardless of what is causing it, the first thing was going to be making sure that we've got good IV access. We start with our fluid resuscitation. If mom needs oxygenation, we're going to oxygenate her, and we want to maintain that normothermia. We don't want her getting too cold early in the process. Then we move into the secondary part of the algorithm, which is activating your postpartum hemorrhage protocols, your teams, then working into determining what the etiology is, what's causing this hemorrhage. And it can range, as you see in the green boxes, from uterine atony to lacerations, retained products, uterine inversion, uterine rupture, and then coagulopathy issues that could be pre-existing or that have now arisen since the delivery. And then the last thing that is in this is considering TXA. So we're going to talk about TXA as well. Next slide. So I love having posters. I love having algorithms. I like for everything to be nice hint things for us when we are working with our patients. So we know that in the hospital, when things start to go crazy in the L&D world, that we kind of all lose our brains a little bit. So we have to make sure that we've got something, and it's okay to have flow sheets and checklists. And so this is just a nice example of how we can initially start to manage a maternal hemorrhage. And it's making sure that we're keeping the ABCs all open and working, that we are working towards making sure we've got those 2 large bore IVs, that we're thinking about blood, we're thinking about blood products, and we're thinking about our hemorrhage medications, remembering that these hemorrhage medications are going to only work if we are talking about uterine atony. And so we've had cases that have come up in our state where uterine atony was not where the bleed was coming from. The uterus was firm, the bleeding was coming from another place. So giving your oxytocin, giving your methergin, giving your hemabate is not going to help in that case because the uterus is already contracted. Next slide. ACOG also has, through the Safe Motherhood Initiative, some great checklists that are great tools and opportunities for hospitals as they begin to make sure that they are working on postpartum hemorrhage bundles and protocols, that it helps keep everything in place and help keep everything kind of lined up with how we're working. So this is just an example of the hemorrhage checklist. You can go see that it goes from stage 1 bleed to stage 2, and the next slide has our stage 3 and our stage 4. So stage 4, they have listed here where we have cardiovascular collapse and we're having to start ACLS. But however each hospital and each provider is adapting this, we want to make sure that your team is all on the same page. Next slide. So I did say that we wanted to talk a little bit about TXA. So for those of you that don't know, TXA has been recommended as a wonderful medication that we want to think about giving when we have a mom who's hemorrhaging. We know that when we give that TXA, because it inhibits that fibrinolysis, that helps prevent that mom basically from going into DIC. So there's been multiple studies since the original woman trial was done on the effectiveness of using TXA, as well as now starting to use it a little bit prophylactically in a patient that has a higher risk of bleeding. So we want to make sure that when we're giving this, we recognize that if it's given within 3 hours after the initial diagnosis of postpartum hemorrhage, we do reduce death. It doesn't reduce the need for hysterectomy. It doesn't reduce the need for other more invasive procedures to be done for mom, but it does prevent death for her. If you can hit forward, I've got another piece to this slide. There we go. So we're going to give 100 milligrams in an IV piggyback. It's going to be diluted, and you're going to give over 10 minutes. So it's 1 gram over 10 minutes. The solutions do have to be mixed, but they should be fairly easy for you to get up from your pharmacy. So I think it's important for all of our providers and all of our hospitals throughout the state to make sure that, do we have access to this? The great thing about TXA is it's a very inexpensive medication. And a lot of our ER departments already have this as a medication. So it's probably already something that your pharmacy can get for you. And we found that giving TXA to moms that are bleeding really does help in the process of saving her life. Remember that TXA is never supposed to be the first choice drug that you're giving. If it's a uterine atony issue, then we want to start with the tried and true. We're going to give the Pitocin, we're going to give the Methergin, we're going to give the Hemabate, we're going to give the Cytotec, we're going to give all those meds, but we also want to be thinking, do we want to give TXA? So as mom is bleeding, what are we doing to help prevent those further complications? Next slide. The other thing that I was asked to talk about is mass transfusion. So I know that in some of our smaller facilities, it's much more difficult to have access to what we consider a mass transfusion. So defined mass transfusion is 10 or more units of packed red blood cells within 24 hours. And 4 units within the first hour. And it is to basically replace that complete blood volume as needed for our bleeding patients. When we think about bleeding and replacing those blood products, in the past, OB patients had a limited amount of blood, and OB units had a limited amount of blood that they had access to. But as we started realizing that if we treat our moms, again, more like our trauma patients, and we get that blood on board much, much quicker, much faster, that we don't hesitate for that, then we help keep that mom from going into those stage 3 and stage 4 hemorrhages. Next slide. So this is just a really nice example from ACOG, from the Safe Mother Initiative, on setting up a mass transfusion protocol. So I have found out, though, that some of our smaller hospitals, while they can't have a full mass transfusion protocol, they can have kind of the startup or the start or the beginning of one that they can start in their hospital. And if that patient needs to be transferred out to a higher level of care, then at least we've gotten started with that blood replacement for that particular situation in that case. Next slide. And I went ahead and included an example of the protocol that we use here at Prisma Health Richland. This was the last that I checked. Hopefully it hasn't changed here. I'm sure someone will let me know if it has. But what they start out with is 6 units of packed red blood cells, 4 units of plasma, 1 of platelets, and then 10 units of cryo. And that's that first batch. And then the subsequent batches you see is just 4 units of packed red blood cells, and then 4 of plasma, 1 of platelet pheresis, and 20 of cryo. When we start a mass transfusion, the great thing about that process is what it's set up in the hospital is you're going to continue getting blood until you say, stop, we don't need it anymore. And so that you're not kind of piecemealing, let's do a couple units here and a couple units here, that it's a complete product that has been thought about ahead of time. Simple things like, are you going to have a runner and who's going to get it? For example, when we have our mass transfusion, we have like the crossing guard orange vest that the runner will go and get. So when they show up at the blood bank people know that that person is there for mass transfusion, and they know to put that person at the head of the line, which also helps. So it's something to think about as you're setting up your processes for safety. And we'll talk about that when we talk about bundles in a couple of weeks. Next slide. So what I want to get us to so that we can have this conversation about estimated blood loss versus quantified blood loss. And I always like to think about this picture that I found on the left is the little candy bar with the candy, the gum balls in the jar, and it's guessing, how much candy is in there. Well, we really don't know when it comes to blood loss. And if we're estimating blood loss, it really is a guessing game. And we know that we're much more effective at treating blood loss when we know exactly how much blood is lost. So that puts us with quantified blood loss. Next slide. So as defined, quantitative methods of measuring OB blood loss have been shown to be more accurate than visual estimation in determining that OB blood loss. We know that there's been multiple studies that say that it is much more effective, and that we are very likely to underestimate actual blood loss when the volumes are high, and we tend to overestimate blood loss when the volumes are low. And so every couple of years, we'll do education for this in different hospitals, and the same thing always comes about. So we can do a couple of things with quantification of blood loss. You can do an improved estimate of blood loss, where you can do training to say, if you have, these are our Chuck's pads, and if a quarter of the Chuck's pad has blood on it, then it should be about this much. So we do like educated estimation, versus where we actually do true quantified blood loss, where we have all of our weights done for all of our dry products. So all of our Chucks, all of our pads, our sheets, the gowns, the transfer sheets, everything that we have is already pre-weighed. So that way we can use a baby scale, and actively during the process or the response to the hemorrhage, someone can be gaining that information. Now, I will say, and I'm sure Dr. Johnson will talk about this too when we're done, is that regardless of the amount of blood that you're seeing or that somebody is measuring, we're putting that to the side, because the patient is the number one. We're responding to what the patient is doing. But we do want to make sure that we've got some protocols in place, and that has been a sticking point for a lot of hospitals, is how do we make quantification of blood loss work for us in a vaginal delivery room, and how do we make it work in the OR for our C-sections? Next slide. So there have been many, many, many projects that have gone on at looking at quantification of blood loss. AWON, the Association of Women's Health Obstetric and Neonatal Nurses, has a practice brief on quantification of blood loss, and they actually have a lot of really great tips on how to actually manage this and how do you set this up in your hospital. Remembering that when we are doing accurate blood loss, number one, it helps recognize the potential for life-threatening hemorrhage, but it also helps us manage that blood product replacement. So while I'm paying attention to labs and things like that, I'm really in the actual moment paying attention to what mom is telling me. What are her vital signs telling me? How is she responding to this? We know that it's not perfect when we look at quantification of blood loss, and I know that's what some providers have kind of complained about before, is, well, it's not 100%. There's not, all of it's not going to be counted. That is true, and no one has ever said it's absolutely 100% perfect. What we know, though, is it is much better at getting what that actual blood loss is for moms. So next slide. ACOG gives us some tips for how to do this, and I believe that we can send these slides out. We'll talk about this at the end, but I'm happy to share this slide deck with everyone. So there's tips for how we actually manage this, both for vaginal delivery and a C-section. And I do know that the BOI, with our involvement with AIM, is working on a webinar with helping hospitals actually start this QBL process in their hospitals, kind of tips and tools of the trade, that kind of thing. So now we're going to get your turn to practice. So we'll go to the next slide. We're going to see how you guys do with estimated blood loss versus blood loss that has been measured. So we're going to look at pictures, and I know that a lot of you in the clinical world would say, well, I would hold it, I would feel it, but we're just going to visualize this because obviously we're not all sitting in the same place. So the next slide. So this is something that we did in the Sim Lab a couple of years ago. So you may recognize Glenn and Alan on that bottom left picture. So we set up some stations. We used a synthetic blood, and it matched up exactly with what blood matches up with. So 1 gram equals 1 ml. So we're able to make that measurement, and we just used a baby scale in kilograms. So you had to just make that small conversion over. Next slide. So here we have A lap sponge, something that everybody is familiar with, and it's got blood on it. And I even opened it up for you so you could look at it and see. So in the chat box, what is your estimated amount? How much blood do you think is on this sponge? So y'all jump in and start typing. This is the fun part. All right, and if you could advance the slides, I get one guess at 75 cc's. So look at that. That was pretty good. Somebody actually guessed 100. That was awesome. So this one was 100. Next slide. So this is the blue sterile towel. The dry weight of the sterile towel is 50 grams. So we'll subtract that from the full weight. So what is your guess on this? It's not fully saturated. You can see there's a few dry spots left on that towel. So go ahead and type in. Got one guess. Oh, we got a big difference. We got 100 and a 50. All right, go ahead and advance. So this is 100 cc's. Dr. Johnson, have you done these slides before?
No. So is this 100 cc's?
Yes.
What was the prior one?
The prior one was, now I don't remember. That one was 100 as well.
Okay.
All right. I looked at these slides so many times. Okay, next slide. All right, so here's another exact same towel, blue sterile towel, that, as you can tell, looks like it's got a little bit more blood on it. So what is everyone's guesses? Okay, we got a 150, a 200, and a 250. Go ahead and advance the slide. And that one weighed at 250, so we subtract the 50 grams, and that gives us 200 cc's of blood. Y'all are better at this than I expected. Okay, next slide. All right, here's the chuck. So this is just a normal white chuck that's underneath mom. We're very familiar with this. We've got the dry weight for the chuck. So what do you guys think? How much blood is on here? I'm seeing 75, 175, 200. Okay, advance the slide. This one is just 100. So we'll advance to the next slide. I want to make sure we have time for some questions and conversation. All right, here's another chuck. What's your guess? Got 200, 250. All right, let's see what the right answer is. 200, good job. All right, next slide. All right, you can see we set up with a mannequin to make it look a little more lifelike for you. What is everyone's guess? Or estimation, I should say. 250, 300, 300. Okay, advance the slide. This is 500 cc's. So you can see how we're already kind of underestimating a larger amount. You guys were pretty good with the smaller amounts, but now as we're getting into the bigger amounts, we're a little bit off. Okay, next slide. All right, so what happened here is we've got the chucks and then we picked it up in order to move it to the scale. So you can see it pooled a little bit there. So that might help you with a little bit of guessing here. I'm seeing 1,000. Okay, advance the slide. 1,000, good job. All right, next slide. One more so you can see. This is what real life looks like, right? When they start bleeding. We probably would have changed the chucks and had that laying on the floor. Too much, very good. All right, advance the slide. This is 1,000 total. There's 500 on the chuck and then 500 that runs down over the end of the bed and onto the floor. I had the advantage of actually knowing how much in the syringe that I was pouring onto the chucks there. All right, next slide. All right, can you tell how much is on the floor? Just looking at that. And I'll just for time go ahead and advance the slide. 500 cc's is on the floor. All right, next slide. I think I just have one more left. There we go. So I think this is our last one. You can see we've actually got some clots now that are being expressed onto the chuck. All right. I'm getting 2,000, right, so 2,000, go ahead, that's fine. 2,500, so there's 1,000 total on the chuck, you've got 500 in clots, and now there's 1,000 that goes down over the bed and onto the floor. So we know here, and so we underestimated for this one, and so this mom would be what would we consider a class 4 hemorrhage, and we would be as Dr. Campbell likes to say, circling the drain at this point. So we want to make sure that we do not get to that point. You can go to the next slide. So we already kind of talked about this, and this is what it usually looks like afterwards. There's a huge mess. And remember that when we're quantifying blood loss, if we don't have an extra pair of hands to do this measurement while the hemorrhage is going on, then we want to do it afterwards, because that again is going to help with that complete replacement of the blood that she's lost. That's going to help us know after we start that initial replacement of blood, how far do we need to continue going with this? And then next slide. So these are the last recommendations, and then we can just open it up and talk. We want to make sure that every OB unit has an organized, systematic OB hemorrhage response. And so that is making sure that we're involving all of our critical care personnel, as well as the lab, the blood bank, our OBs, our anesthesia, nursing, everyone involved. And there's a recommendation by ACOG that we utilize something called the AIM Safety Bundle, which has the 4 R's: readiness, recognition, prevention, and response. And we are going to break down 2 of those bundles at the next ECHO meeting, is what we've been asked to do. The other piece of that is making sure that we do simulations, that we practice, that we do drills, because the more that a team practices, and it doesn't matter if it's always exactly, as long as you've got to make sure that we can get as many people into that process and know, hey, if
Michelle, you're breaking up on us.
We've done training. Glitchy sometimes.
Are you still there, Michelle?
Okay. Hold on. I am. I got it. I'm gonna pull it up here. Oh, will it help if you use mine for the sound? Okay. Can I got muted, so unmute. Yeah.
All right, can you hear me?
Yes.
Okay, I'm on Lynn. Thank you, Lynn. The advantage of having multiple computers. See, what was the last that you heard? Teamwork, bundles, modifying your checklist, making sure I can hear myself. There we go. Making sure that we are working to identify systems issues and correct those, and look for where things are pitfalls. And so we don't have to reinvent the wheel. This has been worked on throughout the nation. And so it's making sure that each facility, all of our OB providers that are delivering in our hospitals across our state are all doing the same thing when it comes to obstetric hemorrhage. And that's all I have. I think the next slide is just a thank you with my email address that's there. So Dr. Johnson, I will hand it back over to you, because I know we probably have some things to chat about.
So thank you, for a very thorough presentation. One